Hi, everybody. Thank you for coming. I'll just invite you to take your seats, please. You can sit there for the moment. We're not going to be sitting at the same time. Mhm. Okay. Hi, everybody. Thank you so much for coming, whether you're here in the room with us today or listening online. My name is Ainsley Newson. I'm the convener of Sydney Health Ethics Network here at the University of Sydney, and I'm Professor of Bioethics within the Sydney School of Public Health. I would like to start today's proceedings by acknowledging country. So we are meeting in a hybrid format today, but for those of us here in person on the Camperdown campus of the University of Sydney, we are here on Gadigal land, which is part of the Eora Nation. And I acknowledge, together with my colleagues from Sydney Health Ethics, that this land was never ceded. And I pay my respects to all Aboriginal and Torres Strait Islander elders, past and present, and also any Aboriginal and Torres Strait Islander peoples who are here today or watching this event online. And I acknowledge and recognise that for thousands of years, Gadigal peoples have shared and exchanged knowledges for the benefit of, and this always was and always will be Aboriginal land. And before I introduce our speaker, I'm also just going to introduce Sydney Health Ethics. So we are a network within the Faculty of Medicine and Health at the University of Sydney, and we are also a substantive academic group within the Sydney School of Public Health. And we undertake teaching, research and engagement. And in doing so, we ask and answer ethical and social questions relating to real-world issues that impact all of our health and our planetary health and well-being. And we do this using interdisciplinary methods from the humanities and the social sciences. And we hope to achieve positive social impact through our academic and public conversations. And I'd also just like to say a big thank you again for coming today. Now, Rachel, I know you are also going to acknowledge Miles in your lecture, but I'd like to do so too. So Miles, Emeritus Professor Miles Little, who died in September last year and was remembered formally at the University of Sydney at the start of February this year, was the founder of the centre known as Centre for Values, Ethics and the Law in Medicine, and which became Sydney Health Ethics as we know it today. Now, Miles was many things. Most of all, a very, very wise and kind human being, but he was also a very innovative and highly regarded surgeon, a poet, a philosopher, and a humanist. And he was a person of great integrity, kindness, wisdom, and thoughtfulness, and we all miss him every day. And so this year, we are delighted to welcome Professor Rachel Ankeny from the University of Adelaide to give the 2024 Miles Little Lecture, and I'll introduce Rachel in a moment. I'd also like to welcome and thank our panellists who will run a more formal discussion of Rachel's presentation afterwards. This is chaired by Associate Professor Tamara Lysart, who's an Associate Professor of Bioethics with Sydney Health Ethics, started here in January. So welcome home to Australia, Tamara. And our panellists, Dr. Sarah White from University of New South Wales, Dr. Sarah Heinemann, an HDR student and doctor with Sydney Health Ethics, and Dr. Hojat or Hoji Sufi, who is a lecturer with us. Trying to find you over there. You moved, sorry. And then we'll have an opportunity for questions, both formally immediately after Professor Ankeny's talk and also after the panel discussion too. So what I would now like to do is to introduce and welcome Professor Ankeny. So Rachel is going to be presenting a talk called Understanding the Roles of Medical Case Reports Beyond Anecdotes to Evidence Generation. I've had a sneaky peek at the slides and we're in for a real treat. I'm so looking forward to your presentation. Thank you. Now, Rachel is a professor of history and philosophy at the University of Adelaide, And she has such a huge range of expertise, interests, and skills, actually. And she crosses lots of areas and fields, including history, philosophy of science, particularly in the biomedical and biological sciences, but also bioethics and science policy, food sciences, and excuse me, philosophy of medicine. And Rachel actually used to work at the University of Sydney many moons ago. She was a director of the Unit for History and Philosophy of Science. And it's really lovely to see some of Rachel's colleagues from HPS here today. Thank you for coming. And she is an affiliated academic over many years and has a history with the Centre for Values, Ethics and the Law in Medicine as well. And she worked here particularly from 2000 to 2006. And very sadly for Australia, Rachel is leaving us in mid-2024 to take up what sounds like an absolutely awesome job. And I'm going to completely fail to pronounce the name of the university you're moving to in the Netherlands. Wageningen. Am I close? No? One of you can pronounce it with the correct Dutch pronunciation. But anyway, Wageningen. Thank you so much, Hans. It is... Yes, I need to get better at that. Thank you so much. It is a wonderful sounding role in a university where I think you will absolutely flourish. So without further ado, I will now invite you to give the 2024 Miles Little Lecture. Welcome and thank you, Professor Ankeny.
Thank you so much, Ainsley. And they're going to swap the slides over. And thank you for the invitation today. I don't know where I'm going to put it. I'm going to put that here. I wrote this down because I thought it would be difficult for me to do this first part, which is just to say, I think you can hear me online, a few quick words about Miles. I met Miles when I immigrated to Australia and I started work here at Sydney. As Ainsley said, I was in the unit for HPS. He welcomed me over to what was then Vellum and to the community there, and was a model of generosity, collegiality, and reflection through what were both formative and difficult times for me as I tried to balance being a new academic, head of school, the only continuing staff member in my unit, and planning and running the joint bioethics program between HPS and Vellum, as well as supervising many students, some of which are in the room or online today, who are now active members of our community, and making major professional and personal decisions that led to me leaving Sydney. Miles was always extremely engaged and supportive, but I have a lot of regrets, and in particular that life's complications, planning curriculum that needed to go somewhere on a deadline, often got in the way of us having more time for real philosophical discussions, especially about our shared interests in the philosophy of medicine. The topic of today's talk was selected with Miles in mind because I think it's something he would have enjoyed and intersects with some of his interests, but also shows the way that my own research has grown and developed over time. It focuses on the epistemology of medical practices that are often neglected in favor of a more scientized and, I believe, inappropriate view of medicine. I only wish that he was with us today to discuss it. Sorry, I was supposed to have clicked this. So there we go. And this isn't working. Sorry, it's not working. Sorry. Thank you. Yeah. I'm sure you've seen that picture, but it was my favorite in the obits. All right, I want to give you an overview of the talk. Some of this will go a bit quick probably because I think I'm trying to do too much. The main kind of claims I want to make are at this intersection of history and philosophy of science, particularly philosophy of science and medicine, if you will, and in particular taking on sort of claims about how evidence is produced. And so in medicine, I want to contend evidence is used in various diverse ways and presented in various forms. And certain types of evidence has in fact become really dominant, and this is largely due to evidence-based medicine and what I referred to earlier as the scientization of medicine. Medical case reports, however, have kind of had a comeback, and I think they deserve a lot more attention. This talk is sort of an overview of most of a book, not all of it, that I'm in the process of finishing, and so I'm really welcoming feedback and discussion. I want to try and argue that we should see them as abductive reasoning. This isn't just sort of philosopher in the sky kind of talk. I think it's important to understand what works in the way it does, because it leads to our setting of standards and other things for a whole range of practices within medicine. And the second thing I want to put a vote or an argument in for, it might just be a vote, I don't know that's a full argument, is that we need to pay attention to practices rather than sort of trying to make medicine look like other fields of science. This is something that's been well recognized in all sorts of areas of philosophy of science, but I think medicine often forgets that lesson. So on with the talk. Sorry, it's still not working. Sorry, mate. I saw that. I was wondering.
Try that.
There we go. All right, I want to do a very brief historical foray. Just to remind you that cases go extremely long way back. And so in preparing for this, I realized they went back longer than I thought. Depends on what you count as a case. But for example, even all the way back to ancient Egypt, we see instances where they're sort of looking at individuals, but writing it down in order to use it for teaching and other things. And in many ways, this one, which has to do with dislocation of the jaw, might not be that different than what we might do today. We probably would know you don't necessarily need to put anything on it, but I mean, much of this is similar to some of the corrections that we would do today. Hippocrates is probably more familiar to you. In the Hippocratic corpus, there's lots and lots of these things that I think are sort of early forms of cases in various ways. But as I'll show you, we come full circle. And in many ways, some case reporting looks a lot like this even today. The only noticeable thing, of course, is their understanding of how things are caused is very essentially different. And I've been teaching a unit at Shanghai Jiaotong Online about complementary medicine. And the interesting thing there is, I think, there's lots of overlap sort of in the ways in which evidence is presented to that corpus of understanding today and these Hippocratic case reports. Galen, Islamic philosophers, all of these people in various ways use forms of case reporting. Galen, even though he's just after the Christian era, very similar to what we would do today. What I loved about this one when I was looking for a good example was his ending, which is this woman who's got what we would call, can't think of what the name is, sleeplessness. But the conclusion is basically she was troubled by something she was unwilling to confess. So lots of psychology going on even back then. Insomnia, sorry. And then, and I'm going to butcher my Arabic, is non-existent. Razi's, who is an Islamic physician, leaves a whole series of these that are quite sophisticated. When we get forward to the 17th and the 18th century, we start to see what we would recognize today. Patients come a bit more into view, and there's a lot of use of dramatic devices. And Brian Hurwitz, who some of you might know, a London-based scholar, has written a lot on the literary form of medical cases. So I'm not going to say a lot about that. I will use some of his material here, but for example, very provocative titles. And I mention this because this is often one of the flaws that physicians or others will point to, that case reports get written up or get presence in literature because they're sensationalistic. It's like bad journalism, right? Girl, 3 years old, remained a quarter of an hour underwater without drowning. It's this sort of thing. But by the end of the 18th century, there's a certain amount of standardization, a certain more part of scientization. Even this one, back to the 1775, we see something that looks an awful lot, both like taking a history and publishing a case report. And this is sort of an analysis of the Edinburgh Medical Journal over time. Modern definition, just let's go basic for a minute, and I'll make it more complicated, is a formal summary of a unique patient, including presenting signs and symptoms, treatment course, and outcome, right? Usually one patient, sometimes closely related ones in a family or a locale. Case report I will use for this talk to cover a whole range of these types because I think they share basic qualities. They tend to be highly descriptive and very naturalistic. And again, someone else's study, 38% of published articles in the big three, JAMA, New England Journal, and Lancet, were case reports. So reasonably prominent. What do we see in a case report? Usually it's somehow unusual presentations of illness. It need not be sensationalistic, but it's unusual as compared to the norms of illness, which is sort of this double think about what we consider to be normal and abnormal. They use a detailed narrative format, often imposed by the journal in these cases. And I've already said, outlining this sort of whole series of things, the focus is on observations mostly, even though diagnostic tests and other things will lurk in the background. The data given is often very rich. It's like a story or a narrative, and it's highly stylized in various ways. The problem, or one problem that we see with case reports, in many ways came to a head with the rise of evidence-based medicine. And I'm going to assume most people here know a bit about EBM. But if we look at case reports, even though they're being published, even though they're out there in the literature, sometimes in the non-research sections, they're considered to be among the lowest forms of evidence if we take this so-called hierarchy of evidence seriously. So, way up the top, we have meta-analysis of multiple studies. Systematic reviews comes in fairly well. Randomized control sort of in the green, so on and so on and so on. Individual case reports come in only after background information, expert opinion, and guidelines, sort of professional. So it's very, very low sort of status of evidence. It is considered observational. It can be systemic in the sense of being produced as a study, but, kind of just barely. So that's partially where the criticism of case reports come from, that they're low quality in terms of the evidence that they provide. And in particular, they're distracting if you're trying to teach, maybe, or even as the reader, because they're only emphasizing the rare, the unusual, the puzzling. Some people have said they're subject to sort of selection and recall bias on the part of the reporting physician or whoever. But really at the crux of it, they're not considered to be real research. They're considered to be sort of fallback, easy ways to publish by people in settings or places where, they're not equipped to do real medical science, inverted commas for those online. They are, if we do actually the data, cited less than clinical research studies. They're not the sort of thing you get a grant to do, at least not in medicine. You might in bioethics, social science, qualitative research. And there was this flat overall growth of them between the 80s and 90s. But then what we see is interesting, and this is part of what got me interested in this topic. We see this upsurge in the later period, and certainly in from the 20 teens onward, with huge numbers of case reports being published, it going back to being a credible part of the medical literature, not huge, but importantly, tons of journals dedicated to case reports. So this was went along with the notion that there wasn't a place for these sorts of publications. They often were very uneasily in the back sections of proper medical journals, along with sort of the black humor and jokes that doctors tell and bad poetry. Now we have, dedicated journals. They range in quality, I will admit, but a lot of them are spin-offs of more prominent journals, seeking to create a space. There also is a case database, and we might want to end up talking a bit about that way of gathering and spreading information. So I want to try and convince you that case reports actually are useful, so long as you take them for what they are trying to do. So first, obviously, based on their definition, they provide a narrative. But the mistake that I often think people make is because that narrative is so specific and so detailed, they think that's what is being done, and that it is about that patient in some sense. But that's not why they're published. If it's about that patient, it just would live in the chart, maybe, or the doctor's head, or the patient's head. The point of publishing a case report is not primarily to get it published, I don't think. There's lots of ways you could get yourself published. But it's aimed at future potential patients. It's aimed at assisting with understanding unusual things that don't meet our usual definitions. So in particular, there's a number of things. Expediting, identifying the next patient who walks through, suggesting a certain treatment is efficacious, that perhaps isn't the obvious one or isn't proven in our strict RCT and above ways. Outlining factors that could lead to prevention. There's actually a fair amount of that in the more public health literature. Refinement of diagnostic conditions. So one of the things I won't talk about today, but that I talk about in the book, is with the rise of clusters of conditions that go largely unrecognized or undefined or not named, there's been this rise of these complex Venn diagrams, also of comorbidities. And in many cases, we need to refine the diagnostic categories with additional evidence. Sometimes people call these garbage bag conditions. A couple people in the room sort of who are expert in these things. With that rise, there's more attention to this refinement of categories. And finally, and this is the real part of my argument, I think case reports are intended to serve as the basis for proposing hypotheses and directing future research. They don't in themselves provide you a slam dunk answer. Instead, they provide you a direction. And that's a particular form of reasoning that's well recognized, but that we haven't given enough credit to. So just sort of the rundown of the range of things. These are some of my favorites or least favorites. I don't remember what I put. It is everything from SARS here in the lower right-hand corner, all the way up to, kind of absurd things like, the use of leeches and how that played out. I think too often when we see these things, there's been two things that doctors like to say about this that get us off track. One is that it's like solving a mystery. Sherlock Holmes is the common example, and that you only have to find the clues sort of in the data. That's not what I think case reports are about. Those are crafted novellas that actually do have the answer because they were crafted for that purpose. It is about puzzle solving, but of a different sort. The second thing is the rise of House MD. Whether you've watched or not, you probably know how it goes. And it's mostly about how people lie a lot, right? But I think there is a moral there that is worth taking on, which is people are complex beings. And sometimes the least important thing might well be your window in. Case reports do that. I think it's important, you can argue about whether this is true or not, but these are the typical ones I think people point to. New diseases such as shell shock in World War I, even Ebola, toxic shock, I've written about this and can talk about it, and AIDS, and I'll talk about that in a minute. Significant drug side effects, particularly thalidomide. New therapeutics, so firsts, particularly surgical firsts, are often like this, and new public health threats. And you can pick your favorite example here. These are all instances where the first publications that came out were case reports. So let me tell you a bit about AIDS. You will know this history to a certain extent if you've read the more popular literature on it, but I want to put it in this window of case reporting. So 1979, a disease that looked like mononucleosis, but had additional symptoms was observed in California among young homosexual men. And all those things were noted as the commonalities. What really kind of got it all going, though, was noticing that men in New York City who had friends in common with those out in California were showing that they had Kaposi sarcoma, which is unusual and really strange among young, not Mediterranean men. There were all sorts of reasons why it was strange and odd. This together led to a case report that was published in Morbidity and Mortality Weekly. And in many ways, that is where the CDC allows case reports to live, for lack of a better word. What's interesting about it is despite the fact that it's often cited in retrospect as this classic reference point, the defining public health issue of our time, the original case report only had 3 citations through the 1980s, right? This was published in 1981. It did hit the newspaper. You can see the parallel article there in the science section. I think there's lots of reasons for that, but this also points to why it's difficult to study case reports. Traditional citation analysis is not going to give you a lot. And sometimes these things are the starting point to something that goes in a very different direction. So case reports definitely start with individual instances or a small group. That's the case here. But this idea of providing information and guidance beyond the individual is the essential added value, if you will. But what I want to really stress at that point is they're not random, they're not contingent, they're not subjective, kind of in the most extreme sense of subjective, or maybe even a middle ground way of subjective. They are constructed against a backdrop of how medicine is understood and practiced and how the human body and human behavior is understood and practiced. They are not just catalogs of unique. There's a selectivity. And that's where it gets tricky to try to formalize what's going on. They are published because the information is hoped to be useful in the future. But a lot of what goes on in them, and this is in some way why I think of Miles, but also more generally, the debates over the skills that are attached to diagnosis or the skills that are attached to other parts of medicine, there is a real skill that goes on here about recognizing what might be important. And in that way, there is a similarity also to Hippocratic cases. They're standardized in a certain way, but the background is always theories. And so if you read something outside of your area of expertise or as a gentle reader outside, you're not going to often understand why this is a case, because it's assumed in a subfield or even in a field, things normally work like this, but this happened and this was different. And that's another reason why I think often cases get a bad reputation. They're taken out of this context. They're taken out of the backdrop of this whole set of shared assumptions that are social, that are indoctrinated through education, that are local in some instances, depending where you're practicing medicine. What's the problem? The problem around evidence is that it seems as though, as much as people might admit they're interesting, they give us a point in, they don't seem to provide evidence in a more traditional way. And that's because they focus on individual instances. And, I used to teach philosophy of science 101 across the way to many, many students. And we said again and again, induction is a dangerous way to do reasoning. It's just a bunch of instances piled up on each other. Leaving aside David Hume, we worry about using induction to make a generalizable point. Second, they're detailed in this kind of personalized, individualistic way, obviously not experimental, even if some experimentation goes on. They're largely observational. Some people have criticized it for using a narrative style that obscures. Now, as I said, Brian Hurwitz and me and others have argued that's not the case. But they lack a methodology, and in particular for filtering out what's important and what's not important. So if you look at historical case reports where something has emerged over time, AIDS being a good example, you'll notice a lot of stuff that's in the original ones has nothing to do with anything. And you have to wonder why things were included or not included. So if we think just for a minute about the key, sort of contenders, and this is very baby philosophy of science, deduction basically is around laws. And if we know the law or a general rule, we can come up with a specific conclusion. Always and everywhere things are going to hold. Now we know science doesn't really work like that in lots of domains, but that's kind of the starting point. And then we make that fancy and complicated. Induction leaves us kind of in this uncertain domain, maybe of a general conclusion that might be true. And what I want to say is, well, first of all, that's the mistake, thinking you could draw a general conclusion. And in fact, that's not what case studies are trying to do. So are they inductive? Well, case reports are usually about small numbers or individuals, but they're not chosen randomly, as I already made the point. There are no controls typically, but case reports aren't used as the basis for a conclusion, and in particular, a conclusion about a group or a population. I think something that's going on there is quite different. Instead, they're used as the basis for proposing hypotheses about what comes next, or inviting others to do so by finding similar cases, coming up with perhaps something that looks like a theory that can then be tested according to some of these higher levels of evidence. This doesn't make them less valuable. So let's go back to, and it was GRID. People probably know the story, gay-related I forget, Roger, what was I can't quite remember. Immunodeficiency. Yeah, sorry, thank you. And, in many ways, there's all sorts of things that are joined up in the story of AIDS and its understanding. So among other things in that original case report, we learned that the patients are active homosexuals, but they don't explain why they're telling us this, right? And that isn't typical kind of in the history. But because it appeared to be something that somehow was related to infection. And so there's a lot of lists of ways in which you can catch infections embedded without telling the reader that that's what they're up to. Importantly, those original case reports, particularly the very first one in MMWR, provided kind of an impetus, but also a way of communicating to find similar cases. And this was important. People were widely separated across a continent in that case, but also around the world as the case unfolded. And the publication provides a mechanism, it provides a way to accumulate this evidence of instances. The structure of cases always is selective in a particular way. And so if for whatever reason, the hunch that it was infectious had proven to be incorrect, there was lots of material in the case that was irrelevant. And in fact, there was lots of material in the case that was irrelevant. But there are always signals of what might be, say, the theory of disease or the theory of how a particular treatment might work. The other thing that was really important was they kept going on about the patients being young. And that is a nod in the direction of saying we need something extra, something beyond the normal. Otherwise, they wouldn't be this sick. And so abduction is the third kind of competitor. There's all sorts of abduction might be a form of induction. I don't want to get into those because I don't think it's very interesting. What I think is interesting about abduction is this idea of putting together often very diverse kinds of things, some of which might prove to be irrelevant. It's an incomplete observation. That's absolutely right. If your norm is something like a law-like set of behaviors, but they do generate predictions. Those may be true. And then you have to do something else. So I'm trying to make an argument that case reporting is a form of abduction. My preferred account is something like what C.S. Peirce put forward. He puts it forward in different ways. I'm cherry picking. If you're a Peirce expert, I probably can't beat you in the argument. But the idea here is that abductive reasoning starts with observations and seeks a hypothesis. And Peirce talks about this, and I like this metaphor, the idea of 20 questions. You know, when you're playing, if you play this game, you know, with a child, you might go easy. You're not going to ask kind of the smackdown questions, probably going to eliminate 90%. But if you're playing with adults, let's say, you know, there are ways to do it better than other ways. So successful strategies often involve sort of testing, as he puts it, a well-chosen or an informative hypothesis first, because you can eliminate 80% of the things you might be guessing. And so as he puts it, the way in which you might start is not necessarily to test a probable one, but to try to rule out a lot of other things. And in some way, that is a sort of essential first form of abduction. And so in particular, lots of things, lots of hypotheses, I would say, are in those initial articles about GRID, or what came to be known as AIDS, that are just kind of all over the shop, right? But there was this testing of boundaries and limits, in some way socially problematic because they were exoticizing homosexual men's behavior and so on. But on the other hand, it allowed things to be looked at and disproven. So again, then as AIDS sort of unfortunately continue to roll out, we see modes of transmission. We start to get to being able to have an actual story about its cause, and then debates about its cause. And in particular, when it goes well beyond the gay male population. And all of these things then were observed again and tested via case reports and in other ways. I want to think for a minute about this use of strategic reasoning and why it's important. And this idea in particular about a well-chosen informative hypothesis. Sounds reasonable. If I talk about 20 questions, you have an intuition what that might be. Going to rule out all women or all men is one of the first tricks, right? But the question is, those are all sort of relative norms, right? Well chosen as opposed to what? Against what backdrop? Informative against what backdrop? And so the additional kind of point I need to make is that I think in case reporting, there's a form of what's called, in the philosophical literature, strategic reasoning used. And here, there's a thinking about what strategy of investigation should be pursued. And in particular then, when you choose to test something, think about, is it relevant? Is it not relevant? Does that go in the case report? Does it not? You're also thinking ahead to that kind of investigational strategy. So my favorite example of this isn't in here. Maureen and others have heard me talk about this before. Hard for us to imagine. When toxic shock, the first case studies came out, there was absolutely no mention. There's very little mention of whether they were men or women, teenagers mostly, young. And there's absolutely no mention of the women's menstrual status. And we're thinking, that was dumb. You know, isn't that what it's about? But it wasn't, because the toxic shock they were seeing was a much broader category of reaction to foreign bodies, right? And it took them a very long time to figure out that some of that other stuff that probably was lurking maybe in the history somewhere was relevant. You know, were they tampon users and all that? And so then we get the spin-off category of what becomes toxic shock. Again, it all depends on what you think you're trying to understand. And so this investigative strategy is keyed in not only to the background assumptions, not only to what you already know about what normally happens when people get sick in this way, but also how you can investigate and understand what you're seeing in this deviation from the normal way of being sick. And in particular, these sorts of strategies usually are two-pronged. One is somebody's walked through the door and they're miserable. You need a way to treat them. Now, often we only see it in the case report when they're dead. So a very large majority of case reports, there's two endings. Overwhelmingly, the patient dies, and then the heroic doctor figures it out later. That's sort of the narrative. Or they improve, right? Quite a lot. So you're seeing the whole picture, but from a very particular point of view. But what's being recounted is what you do when this person walks through the doors of a clinic. This is not theory. This is real practice. And so there's this simultaneous desire to figure out what's going on in general, if you will, or at least for the next 3 patients who walk through the door who are like this, and do something particular for this patient. And so when the strategic reasoning is used to say, what next? What do we do to understand this patient? Or what kind of hypothesis should we test? It's this mixture of both clinical and practical kinds of aims and these more research-oriented, even theoretical claims. So cases are always relative to background knowledge. I've made this point, but hypotheses have to be testable. 101 philosophy of science. But if we think about this factor of being strategic, the idea is that inquiry can be economized and expedited because you're not starting from scratch. And so there's this considering of what is plausible against the backdrop of theories of disease, for example. But the nice thing about abduction, if I were to go back, but I won't because I'm too scared to go backwards, is that you can put in new information. That's the whole point of that kind of complex, not complex, overly simplified graphic with 3 overlapping shapes. So the hypothesis that AIDS was an infectious disease was plausible based on everything that was being seen and accounted for novel observations, namely very young people who were very ill and dying. One of the wonderful things about abductive reasoning that I think often we've overlooked when we think about the practice of science is that it allows this kind of novelty to be incorporated. It's more creative. It allows, it's not just testing the theory yet again, you in fact need a new theory. It might just be a tweak on the old one, but it's a pretty important one because you couldn't figure out what to do for this patient. And I think case reports should be seen as sort of coming out where there's been a failure to be able to use existing theories or existing approaches. It allows an inferential process to occur that links the case report to these new things that you can test. And I think this is a much better way of capturing what goes on in medical case reports. Finally, I think case reports have to be seen as an important form of medical literature. I've already said I don't want to talk about them as literary, but as a form of publication, I think it's really important to realize they have their own rules, they have their own structures, they have their own sets of reasoning. And one of the key things is to generate dialogue in the sense of, kind of flush out other instances. Now, it's not the case that all case reports are successful. And in fact, when I've started to do this project quite a long time ago, I tried tracing case reports. And the problem is most case reports never get taken up, never get cited. So you end up with this sort of negative evidence galore. But when they do, this is the sort of process we see. When they work well, but it often takes a very, very long time. And the curve on case reports actually coming into their own and taking hold and being of interest for research is worse than any curve on any or delay of any philosophy publication getting cited. It's extremely long term. So I think I've made this point probably to death, and I realize I'm getting close to time. The last kind of bell and whistle I want to add on this is that I think there's an important way in which abduction also intersects with the notion of pursuit worthiness. And here's where we really need to stress, you're not going to get a truth claim out of abduction. I've already made that point, but that it can do something like tell us what's worth pursuing. And here, the philosopher of science who died not too long ago, Larry Loudon, made the point about the idea of pursuit-worthy judgments is really an important thing, just sort of the day-to-day practice of science. It tells us what's worth pursuing, perhaps against the backdrop of a particular situation, our values, and so on. They're practical. They're highly iterative. And all of these things, I think, are extremely important because medicine isn't something that happens in a lab or just in a lab. It's something that happens in a clinic and every other setting you can think of. So this is going to cause us to revolt a bit against sort of traditional accounts of science, which hold explanation as the main goal. Medical reports provide something different, and not all science is about explanations. I think this is a really good instance where other sorts of things are going on that isn't just focused on sort of traditional explanation, deductive, et cetera. All right. So in the last few minutes, I want to sort of apply this in a specific instance. There's a few others that I've worked up, but I think emergency situations provides a nice window. Case reports are really useful in any instances where time, resources, other practical limitations, which can be social, economic, and otherwise, don't allow for RCTs, ethical reasons, right? What is important is to figure out how you're going to get high quality evidence. particularly when we're thinking about something like an emergency situation with public health implications. And I think pandemics are a really important instance of this. So my dear colleagues, John Dupre and Sabina Leonelli at Exeter, have a nice article looking at problems with the way COVID was dealt with very early in the pandemic. And they make a good point, traditional philosophy of medicine point, that you always have to fix your entity, which means sometimes we kind of call something a disease before we know enough, right? And in particular, that was a mistake because COVID was highly unstable. It was evolving. We didn't know what was in, what was out, what was COVID, what was something else, and all of this. And that people tended to engage in undue what they call reification. So taking the entity too seriously, I guess in plain English, giving it a higher status than it should, to be more precise. And that would have been maybe okay, but they also failed to question that or recognize it. And this resulted in all these static definitions being used, which in turn led to problematic data and models. And this is still a problem as we've seen COVID changing, evolving, and so on over time, the virus in particular. I'm just using COVID as shorthand. They make the point that there were few systematic provisions for capturing changes in phenomena and responding to the temporality and the specific provenance of data. I want to claim that's actually not the case. Case reports can be systematic and they can play this sort of role. So to do this, I want to look briefly at the 2009 H1N1 pandemic. And here we have something that kind of came to an end in a way, but at least we have resolution. And we have a great little case study where the World Health Organization asked its member states to provide case-based data on the first 100 laboratory confirmed influenza cases. And the goal was to understand these very earliest days and how bad it has to be hospitalized, right? Now, maybe you can see the problem already. The problem is when you're going across very diverse member states, you're going to have very different kind of reads on what counts as first laboratory confirmed if you're thinking about this disease as something in the world. If you're just thinking about in the lab, was it positive? Maybe. That's where we get sort of the reification and the overstatic. So they received over 18,000 case reports, pretty short period, less than 2 years, 84 countries. And then they realized the data was wildly inconsistent. Not only did it get to them at different times, it just didn't contain the information they were hoping to get. So there was the stabilization of the phenomena through saying, what we care about is a positive lab result. Tell us when you get it and give us a little bit of information. And it just resulted in wildly differing things. And what you notice, I don't know that you can see this very well, but when you look at this in a little more detail, symptom onset date, you'd think this could tell you kind of how the disease was spreading, but there's a direct correlation between the amount of healthcare resources and when things were observed. So the yellow is sub-Saharan Africa, and you see these peaks and troughs that are in weird places. You also see the overwhelming majority of cases that were reported are in black, because that's Europe, right? And so on. There's all sorts of things that you can observe from this. This does not actually look like how the disease probably spread from what we know about these kinds of infectious diseases. So in a sort of meta-level analysis, not a meta-analysis, but a sort of reflective analysis, Williams et al. Say, a better approach would have been to identify critical questions, standardize some data elements and methods of investigation, and create effective channels for communication. You can't just take the presence of the infective disease to tell you much about how a pandemic spreads. And here what we see, these are in a sense case reports bundled up at a national level. Again, we see the need to actually articulate the question you're trying to ask, standardize at least some elements that go well beyond the disease entity itself, and make sure there are robust means of communication. So one step has been taken. The kind of community that's centered on case reports all the way back in 2013 put together a set of guidelines, which sort of goes to having components in case reporting that are the same all the time. They've been used in some fields, they've not been used in others. Some of their more interesting and innovative components have been not used at all, and that's a discussion for another day. So patient voices were encouraged as part of it, and just looking in the literature, but also asking Michael Kidd, who happens to be Australian, and they just haven't seen it come through. He was one of the main promulgators of this before his COVID moment. And so in some way, they've had their place, the systemization is there, but there's still a lot of work to be done. So if we look at the findings from COVID, what we see is aggregated data provided really important information, but reflective pieces have shown disaggregated data. In other words, things that weren't necessarily bundled up for shorthand in ways that made assumptions was also critical, and particularly over time. And that's, again, exactly what case reporting provides. I don't like the expression raw data, but it provides information that's been often unfiltered. So the argument I want to make is case reporting is really important, particularly in so-called fragile settings. That might be a lower income country with less medical care. It might be a place where culturally you don't go to the hospital till you're nearly dying. That was one of the problems with the flu reporting. It might be a fragile setting where we normally have enough technology, but oh, we have this COVID thing and we no longer have enough resources. So it can be a well-resourced place under extreme conditions. Case reporting is important because what happens is that patient needs to be dealt with in this context. And unfortunately, that context will recur, be it a pandemic, be it under-resourcing, be it social and cultural or ethical considerations. And I think further, there's a need to take seriously institutional empowerment about collecting this kind of data, even though it doesn't look like an RCT. So I don't want to talk about that. Some general lessons. Emergency health situations have certain commonalities, pandemics and so on. Rapid creation of evidence necessary, particularly where there's a public health threat. Crowdsourcing in a sense of information, often unfiltered, raw, not systematic. Uses of approaches from big data, which might be part of the answer to this, but the lessons still hold that we need to know how to structure it, how to query it, and using established scientific practices within their limits. So some standardization, but also open sharing so that others can contribute similar or wildly different. And finally, the need to be open to different ways of understanding what counts as evidence, what it's evidence for, and even what the entities of study are, particularly where diseases aren't clearly defined. So case reports are extremely valuable, I think. There's a need more generally to change this view of case reports because they do allow us to capture fluidity and change, and they allow for attention to more equity, settings that are non-ideal, household conditions that are non-ideal. And this is a plug for scientific activities occurring in social, cultural, ethical contexts, and in which case we really do need to think about case reporting as a form of evidence generation, or the first step. So I found myself going back to this. I may be the only person who's old enough in this room, there's people online, I think, to remember Miles wrote an article called A Gentle Critique, which was very Miles because it wasn't a particularly gentle critique, frankly, but the title was A Gentle Critique. I will admit, this is a not so gentle critique. He was critiquing evidence-based medicine. And this goes along with a whole line of research he did, a lot of us published out of and so on in this particular period, 2003. And so he drew out flaws of evidence-based medicine. You see it down the right side. I found myself sort of starting to say case reports, when they're done well, have certain advantages that in some sense are maybe the reciprocal, not quite the inversion. They're complex, they're non-reductionistic. They are open to patient perspectives, just haven't quite figured out how to do that yet. Doesn't pre-assume what counts as evidence. There's no dependence on kind of these ideals of how you might test or could test or want to test, but you can't. This sort of forcing into a certain way of understanding what counts as evidence. They don't aim to produce truth. So this is a response. You know, Miles's point was EBM says it's telling us how it is, but these are unstable truths. Case reporting doesn't even go there. It doesn't seek truth. It's got another goal. It keeps the individual in view. The individual might become a sort of type, but it's not trying to, you know, always just diagnose huge categories. The individual is firmly in view, very vellum kind of point, deeply embedded in their histories and in the history of our societies, and maybe most importantly, passes on the criteria that he really found problematic for EBM, namely, they're kind of contemptuous, partially the way the literature is written, but there's a contempt for sort of what worked in medicine and came before. I would add the point that case reporting in particular doesn't do that, but it also draws on this sort of phronesis, the skills of the really skilled diagnostician that's difficult to kind of put into formalized ways. And so in conclusion, I want to say, I hope I've convinced you case reports are interesting, useful, and that they are existing in this really important space that I think we have come to recognize in part through recent pandemics, between individuals and the generalizable, between the ideal and the really fragile and difficult circumstances that we exist in. It's important to do this in practice, not just in theory. And this is just another line of the kind of work I've been doing lately, is really just looking at what people actually do. Now, footnote, I'm looking at published cases, but I think this is kind of a hybrid or an intermediary kind of category where you can get a window. I did think about going to clinics and waiting for a case to occur. Probably could spend the rest of my life doing that. So this is the best I could do. I think medical case reports can serve as part of the basis of knowledge, but this does require recognition of the underlying reasoning, everything that goes along with case reporting, and what they're actually intended to do. Thank you. All right.
You didn't go over time at all. You actually were slightly under. Amazing. Thank you so much, Rachel. So just before we formally start the panel, we have a few moments for some questions, and we're in with a bullet. Dominic, I'll grab a mic for you.
I'm supposed to be up here. All right. Hey, Dominic.
Thanks. Hi, Rachel. So a form of reasoning that you didn't talk about, but which I think is connected to the first point about eliminating possibilities, is analogy.
Yes.
Is this instance like this case? Now, analogical reasoning has a dubious reputation for good reason as a kind of way of establishing truth. But one good thing about analogy is spotting when an analogy does not hold is cognitively dirt cheap, right? It's much easier than rigging up a model and trying to test them, testing the model de novo. So I guess I'm inviting you to maybe say a little bit about where you think reasoning by analogy comes in, and also whether that connects to what is maybe not exactly case study reasoning, but something which is very common, which is the kind of thing you get when, sort of reasoning from examples that you see when people say things like, is Putin's invasion of Ukraine more like this historical case than that? That kind of stuff happens all the time.
Okay, so there's a couple different versions of an answer here. So analogical reasoning everywhere, right? Including in science. I'm sympathetic to thinking a lot of what goes on in animal experimentation is baby analogical reasoning. I've written about that. I've bashed that to death. I think, like anything else, there's good and poor analogical reasoning, and it all depends on what you're trying to conclude, what you're looking for. And I think using a social example is nice because it takes us into that domain. So, and in fact, I can't quite remember what it was last night, but I remember hearing it was about the invasion of Russia. And one of the commentators was making a point, it was like something, and I found myself thinking it was completely different than that, right? And thinking to myself, but it's interesting because that isn't one that I've heard before. And what do you do when you do that? You compare different sort of things that live in the description of case A versus case B, and so on. You think hard about the background assumptions. What kind of person is Putin? What kind of place is Russia? What moment are we in? All these other things. But I don't think analogical reasoning takes you to a point of something you can test. So that's why I think we use it a lot in the social domain, because we often can actually then go ahead and test it, right? They're very weak claims. It may well be when you're doing in the sort of prehistory of a case report, it's finding, oh, this person is nothing like what I thought it was going to be, right? They came in, I thought it was going to be a simple case of an infection, and oh, it actually proves to be different on this, and this a point. And then, oh, they come back and they have Kaposi's sarcoma on top of everything else. Okay, they're really disanalogous. That hasn't really gotten me very far, except to say they're in some basket over here, which means I'm in big trouble, right? I think the other thing that I should have said that I didn't say is, of course, case reports are used in all sorts of subfields within medicine, and in some places have the reputation or the status of being far more systematized and recognizable. Psychiatry and psychology being a really good example. I shy away from that. Warwick's got his hand up. Hans is sitting there. You're sitting there. I think these things have had their place, particularly in psychoanalysis. And it's the way that people talk, oh, that's like Dora. Oh, that's like, whatever. Many of the sort of important case reports in general medicine, which is where I started this, don't have that kind of status. They're much more muddy than that for good reason. some of the things that we use in teaching medicine kind of have that status. And we can debate rightly or wrongly, but I think that's where we sort of ply on people's tendency to use analogical reasoning, right? Oh, isn't that like, the instance of the guitar, we use it in ethics all the time, the violinist and, these kind of using even sci-fi or cooked up toy examples. But I think we hit a wall really quickly. It can be good for pedagogy, but it doesn't get us to the next step of sort of the medical side, the scientific side of medicine, if you see what I mean.
But it might help you rule something out really quickly. Yeah.
And I think what happens with case reporting, that happens and it's invisible, right? Unless you get a really reflective one where there's sometimes they do the pre-discussion, patient walked in, I assumed it was this, and they give you all that stuff. And then, you usually don't even get that part, right? Sorry.
Thank you. Professor Warwick-Anderson, you have your hand up online. We're actually not entirely sure whether when you speak, it will come through the audio in the room here. So could we just test that to start with?
Hello.
Yes, we can hear you. Brilliant.
Rachel and everyone else. Can you hear me?
In the queue, Dr. Supriya Subramani, and then we'll see how we're going for time. Thank you.
Sure.
Please ask your question, Professor Anderson.
Okay. Thank you, Professor Newsom. Yes, thanks very much to Professor Ankeny, since we're in that mode. I wonder whether it would be helpful to make a distinction between the case study and the case report.
Yeah.
I've heard a mixture of the two. I once
talking about case reports.
Yeah.
Case studies are very different than social sciences, right?
So let me explain. I couldn't quite hear because I was talking over you, but anyhow. But look, I once wrote a case study with others in 1989 on acute theophylline intoxication, which was very much about the individual. I later did some case reports on recourse to complementary therapy among people HIV positive in the Philadelphia area in 1991. And they were very different projects. One was very much oriented towards the clinical. The case study was oriented towards clinical information. The other was more epidemiological intelligence. It was a function of epidemiology. And so I wonder if this would be helpful to make that distinction, because I think you've put both genre together there. Or do you think it's a false distinction?
So the traditional distinction people make, most of what I was talking about would be case reporting. That's usually kind of in a medical context, often what it's called and how it's understood. The terminology of case study often comes more out of the social sciences, where it is sort of an effort to get to a type or to create a typology. But it is the case that there's slippage, right? So I think it depends on context. I mean, you yourself just said, I'd need to know a lot more about the first one, but it might well be what a lot of people would call a case report. What I think is important is the kind of activities that go on. And as you said, the second type is aiming to get to something that might help us with epidemics or pandemics, what we now call epidemic intelligence. But it also had clinical connotations based on what you said, right? So I think it's hard in the abstract to be consistent about those uses. I slip, even though, I've been talking about this stuff for a very long time. What I do, I try to avoid calling them cases, because I think that does invoke something more like a medical case that is simply in the clinical setting. And so the genre I'm interested in is where things are published as N of ones or small groups in a medical journal and presented in some way as a case or a case report, and sometimes as a case study. But we can keep talking about it, because I think this is a bit of a difficulty, how much you use the actors categories, and even those have changed over time, without going down the rabbit hole of similarities and differences to their use in the social sciences, if that makes any sense.
Thank you. We have another question from Supriya.
Thanks, Rachel. Really resonated with a lot of thought process with as a qualitative researcher. Like it just
Yes.
resonates totally. And then, so one is a thought or a comment based on the observation of the H1N1
Yep.
graph. Like who gets to write cases? Who gets to publish cases?
That's right,
Which
yep.
country? So the reason why I'm saying is like on one hand, the idea of, which countries publish. So I'm thinking who gets to say and who gets to publish is one dynamics playing out. The
Yep.
second is a question. It is like, so basically evidence-based, especially the positivist framework, which we are resisting, right? Especially within the questions of evidence-based medicine, how do we bring narratives as part of the mainstream discourses? And that's what you're talking about, abductive reasoning. And I'm wondering whether abductive reasoning would do the work for that. Because if, let's say, I'm not sure, I'm just
Go on, yeah.
thinking through, if the idea is to question the positivist paradigm, let's say, of the idea of evidence, then the constructivist framework, if talking from the constructivist framework, would it help? And if that is the case, do you think abductive reasoning fits into constructivist framework of the way the knowledge or not? Because the
that's
language of
huge.
hypothesis is something very interesting for me here. That's
Yeah.
But yeah.
So let me start with the first because that's the easier one of the two. Some people argue that case reporting is a much more democratized genre of medical literature because you can do it based on an individual instance. And if you do, and I've done some rough and readies, you see a much bigger diversity of geographic locales among first or subsequent authors than you do on just an average search of medical literature in the same period. Now, the issue there is what doesn't get published. Again, difficult to study, talk to the people who run some of these case report journals some. There still is a bit of credentialing that goes on, but there is a deep sort of agreement that this is a way of democratizing, A, but B, more importantly, some of the most important evidence about stuff that's offbeat is going to come from not your usual locations, right? And so you also see a greater diversity of subfields of medicine represented. I push back a little bit about the democratization thing because I think it still has vestiges of this is second, third, fourth best form of publication, And I think for certain subfields, for certain places, certain times, case reports are a very valid form of publishing. And there are better and worse case reports, right? In particular, because there are these systematic structures. Second question. Personally, I don't take a very objectivist in the capital O truth kind of objectivist way approach to anything in science, let alone medicine. To me, if I'm going to favor anything, just to make it really simple, it's that people use that word objectivity, but it's socially constructed, like Longino or people after her. There's problems with that account because it doesn't want to hang on too much. But for somebody who sits in between the philosophy of science, the philosophy of medicine, bioethics, and so on, I do think there are still vestiges of this desire to scientize medicine that go back a long way in history. I just kind of play it being a historian, but I have some background and you can really see those vestiges to this day. So that means I feel as though I need to at least entertain that language or that framework when I'm talking about what I'm seeing. Would going all the way to something like a much more subjective account of health and disease make sense? Yeah, probably. We knew that a long time ago. Do we do it? No. Why? A whole variety of reasons that have to do with insurance, socialized medicine and repayment, approving things, all these structures. And in lots of places, then we don't, and we use a much more social approach to medicine, right? But I still think in so-called Western medicine, a more scientized approach is the norm, even if an individual doctor will tell you they largely believe it's a biopsychosocial kind of model. Is that what you were trying to get at in the second question? Abductive reasoning. My claim isn't necessarily what we think we need. My claim is more of a descriptive claim that I think this is what it's going on. And then again, I think there's going to be norms and standards that you have to articulate about what makes for good abductive processes following, starting down that track. But in effect, I'm trying to make us focus on this sort of stage in medicine that often we sort of ignore. We only, it only gets traction once it becomes a randomized controlled trial or some such thing. Yeah.
Okay, thank you very much. We still have 2 questions in the queue, but it is time to move on to our panel discussion now. So Diego and Maureen, I will prioritize you for the general Q&A at the end. So I'd now like to welcome Associate Professor Tamara Lysart, who's going to chair our panel. Tamara, as I mentioned in my opening remarks, is a fairly newly appointed associate professor with us at Sydney Health Ethics, but a graduate of the University of Sydney. We're delighted to have her back. And Tamara has expertise in ethics and regulation and governance of emerging science and emerging biomedical research. And she works on policy relevant ethical issues in things like stem cell research, genomics, precision medicine, reproductive technologies, etc., and with a focus on empirical and deliberative methodology. Thank you so much, Tamara. And you're going to introduce the panel, aren't you? And I will bring some microphones.
Thank you. Well, the lapel mic is coming. I thank you very much, Ainsley, for this opportunity to facilitate this panel. And of course, thank you, Rachel, for a really, really interesting take on abductive reasoning and case data reports. I'm withholding my chair's privileges to ask questions later, but I would like to first invite our panelists up into the sort of front area. It's not really a stage. So there's Dr. Sarah Heinemann, who is a medical oncologist and is currently studying a PhD with us at Sydney Health Ethics. Hoji Sufi, who is a lecturer also with us at Sydney Health Ethics and is a pharmacist by training, but is now flourishing in an academic career with us at FMH, at the Faculty of Medicine and Health. And Sarah White, who I've only just met today, and she is a conversation analyst and communications expert at UNSW Centre for Social Impact. Oh my gosh. Okay, so thank you. Please welcome everyone. I had yes, I had intended to keep this panel quite informal, but I would, to start with, I wanted to invite each of the panelists to just give a brief commentary on some of the topics that Rachel has discussed in her presentation, and these can be as substantive or topical as you wish. I will then give Rachel opportunity to respond, and then we'll open it up for a wider discussion and contributions from everybody in the audience, offline and in the room. Thank you. Now can I have it?
Is that on? Is that on? Is that? It's on? Yep. Okay. Hi, everyone. How come I have to go first? So thanks very much for your talk, Rachel. Really enjoyed it. So many thoughts where to even begin. I found it interesting that I had the impression that you were defending medical case reports, whereas to me as a clinician, and maybe particularly within my area, like the value of case reports is really strong. So I'm a medical oncologist by trade, and I think certainly in our area, the rate of publication of case reports is only going to be more important as time goes on for a variety of reasons. Part of which, like, to echo the person before about describing sort of trends from an epidemiological sort of perspective. I think part of post-marketing surveillance in an area where drugs are approved quickly because people don't have long to wait for our drugs. And so there's actually like a role in terms of being able to pick up sort of new signals, safety signals, that sort of thing as well. And in some ways, I guess that is a bit of a counter to sped up science, if you like, whether or not there's sufficient systematized ways to sort of gather that evidence, I guess, is a different question. I think in my area as well, like the advent of like precision medicine too, where we're increasingly sort of recognizing that they're not patients with cancer or certain tumor types. Every patient now has like a rare disease, and every patient with a rare disease is worth describing. Increasingly, I think the ability to be able to see the N of 1 experience down to sort of the molecular level because of pharmacogenomic sort of implications for using different drugs will be actually relevant clinically as well. Yeah, I guess the other sort of comment or thing that I found interesting was in my mind trying to sort of unpack sort of overlapping things. So the conversation about case study versus case report was interesting. I'm kind of not quite sure where the boundaries begin and end for anecdote or even, so my interest is in clinical trials, the concept of N of 1 trials, where those boundaries begin, start. How do you determine what quality is in each of those areas? How do you appraise each of those areas? And then just as a final thing, I think like your comment around sensationalism was really interesting. Obviously, someone doesn't write a case report unless they feel that there's something interesting or they've got a story to tell. Yeah, it's interesting seeing the different ways in which case reports or something like them can get used beyond sort of the traditional scientific media and sort of the hype of things as well. And yeah, it just reminds me like even of like I guess at hat tipping miles, like the concept of intellectual virtue in this area as well. So in Kerry Jetty's ARBL keynote last year talked about the role of intellectual humility in early phase clinical trials. And I wonder whether this is a situation where this applies as well. Thanks.
Do you want to respond to that or should I move?
Just go down and
Yeah, first, thanks. I really enjoyed that. I'm convinced that case studies are useful, as you mentioned. So I want to provide that reassurance to you. I have 3 questions. One is about, so moving on from drawing on what Dominic mentioned about another kind of reasoning, which is analogical reasoning, and more specifically about casuistic reasoning, which is a specific form of analogical reasoning. And I thought that maybe actually in some cases, one element of casuistic reasoning is you want to compare a given case to paradigm cases. And I thought that in some case studies, the paradigm case is not there. So, so casuistic reasoning or more broadly analogical reasoning may not be relevant to all case studies, but I'm wondering what you think about that. So there are cases that you cannot compare to any other given case because they are so unique. There are some distinct features that we do not have any benchmarks to compare to, or at least the comparison would be so distant. The second question that I have is about, so this is how I want to summarize your reasoning. So you looked at successful case studies and you tracked some features such as the use of abductive reasoning or some form of standardization or some form of systematization. But I was wondering that perhaps in those successful cases, there are more elements. So in the case of AIDS that you mentioned, I thought that maybe another element is the political element or the advocacy element. So perhaps if we want to explain why case study took off in that situation, perhaps there are some other aspects that are not down to the way that the cases were reported. So, and if that's the case, what should we make of it? And the third point that I want to make is that so I'm a bit curious about your view on the relation between case reports and truth-seeking practices. So, in one sense, all of this is about the truth. So we want to see whether or not some hypotheses lead us to true claims about what is happening in the world. Or I mean, in the case of AIDS, like what is actually a true explanation of the causes of that disease. And in that sense, yeah, so one might misinterpret your view, I think, by saying that, okay, you are just, you are truth aversive or something like that. And yeah, truth aversive or not adverse.
Yes.
Okay, so I actually, so that's not a misinterpretation. Yeah, so that's not a misinterpretation. Okay, so yeah, so you already then can guess what would be my question. Like, so if we just abandon that, what would be the epistemic cost of it? Yeah.
Yeah.
Okay, thanks. Yeah, thanks. You have one?
All right. Thank you so much. That was really interesting, and I think because I come from a field that uses single case analysis as the bedrock of the field, so I was really interested in the positioning of case studies, case reports within medicine, and I've often critiqued the over-reliance on things like RCTs myself because of a few different things. And one of those is the scientific approach within conversation analysis actually begins with single case analysis. So it often begins with a noticing of something that's, oh, that's interesting, that's different, why did that happen then? And going through that process of inductive and abductive reasoning to then build to the point where we've been able to have RCTs and things like that, and have bigger numbers, because sometimes people like those things. And so I was really interested in I suppose, where case reports sit within the broader kind of scientific, process. And how they connect. And I thought it was fascinating that there are often not very many citations, while you get kind of the opposite happening a bit in conversation analysis, where, it's those kind of single case analyses that are really that foundational kind of work and considered, important, and, you would be dismissed for, not doing your work properly if you weren't to start at that point or to draw on that work. So yeah, I was interested in that. Also in the idea of how reductionist other studies can be. And with conversation analysis, we're looking at conversation, which is considered a context-free system used in a context-sensitive way. And so thinking about that idea in terms of medicine, and it's a context-sensitive individual case that's then, becomes decontextualized if you look at larger numbers. And then the need to then recontextualize those numbers when you are using that kind of research to then provide care, and the challenges of recontextualization of that kind of data. So I think that was the kind of things that I was interested in from your talk.
Okay. So let me see, I might have to do it in the order that people talk, but it will overlap a little bit. If I go back to the initial points that Sarah number one made. Yeah.
We can't hear online.
Sorry, can you hear me now?
Yes, much better, thank you.
Sorry, that was me in the mic. In different fields, cases have different case reports. Sorry, case reports have different status and different sort of plausibility as reasonable forms of communication. So I think it's not just, what's going on, like an epidemic time or whatever else, it's also subfields take it in a different way. I think there are very different ways in which they're used. This goes to the other Sarah's question about process. Today, I focused on one particular use, but in the book, I'm looking also at things like adverse events reporting, which is closer to something like post-market surveillance, and this sort of thing. When we have what you called kind of sped up science, but we need to step back and at least try to make sure we're not really doing something wrong in effect, right? And I think those are the kinds of contexts where we do see a lot of the overlays, Hoji, that you're worried about, of politics, the social, and so on. People are dying anyway, and so you may as well, but there's still, ethical and scientific reasons to have ways to do post-market surveillance. or to have adverse event reporting. It's just hard to do well, right? It takes a lot of investment. It's not particularly sexy. It's only meaningful when you discover something that's really bad in some way, right? So that's why I really liked your comment, Sarah, about precision medicine, because it's something I've been wondering about working in kind of to the end of the book, because I think it is really interesting, have we gone to that extreme? You know, every patient is an N of one, and in some unique way is a rare disease. And, you know, I think about that also to a certain extent when I compare things like veterinary medicine on animals we care about versus veterinary medicine on groups of animals. You know, we do this all the time. One of the things that's clearly going on here isn't that there's anything fundamentally different between us and other biological things. It's just we care about the details more because it is humans, right? And so I try to kind of get my head around whether there's an in-principle difference or whether all of this is just a function of what we care about. In other words, this thing that we call medicine, which is uniquely human in some way. You know, Pachi, you know, veterinarians who care for pets come pretty close in sometimes. But then this goes back to the question from earlier. You know, in that case, we kind of simultaneously keep in view something that's quite a constructivist, if you will, notion of medicine and a constructivist notion of truth. Because my answer to you, Hoji, would be, I think in a lot of scientific activities, we're not looking for truth when it's applied science. We're looking for the ability to intervene, control, or change. And perhaps we don't even really care how it works. Or at least, you know, in the moment, we don't care how it works. And so, you know, this is something else I've argued, that a lot of clinical medicine doesn't have the same notion of causation that research medicine in the lab would. As long as you can intervene, we kind of don't really care how it works. We might in the longer run, but when you have a patient who comes up, you're treating symptoms, right? And as long as you can manipulate and jump in and intervene in that causal chain, it doesn't matter if it's the cause, the main cause, or whatever else. Now, to go back to Sarah H's point, that gets interesting with precision medicine because it feels in some way we are going back to sort of saying, you know, the genetic is the thing, right? But it's become in a way a proxy for the complex milieu against which disease is enacted. So I do think that was a really useful comment, because I think it would be good to get into more detail in a way about precision medicine, because I do think that's the way it's going. So Hoji, I sort of answered the truth-seeking practice thing. I think that's what we typically think science is up to, but that's precisely what we've determined science has limits on. If truth has inverted commas around it and we're thinking, you know, close enough for government work or for getting something done or for having an idealized assumption that allows us to do something else, yeah. But I don't think it's a capital T kind of truth-seeking thing, let alone something as hybrid as medicine. I do think it's really interesting to think about the paradigmatic cases. You and I have talked about this before in casuistry. I mean, I think lurking in the backdrop, goes to Dominic's question, is sort of some sense of a paradigm case, which is like the classic, you hear doctors talk about the classic case of ... And this is not that, right? I just think they're often not as well articulated. In many ways, differential diagnosis is, in a sense, taking a whole range of these classic, I don't like paradigm, classic cases, and saying these are the backdrop against which then we determine what's weird and wacky. So I do think there's a little bit of that going on, but I only think it's the same answer I gave to Dominic. It only gets us so far. Then when I move to Sarah W.'s kind of comments, you're absolutely right. I think the social kinds of work where the starting point is essentially different because you are starting from single cases is a really interesting thing. But where does the idealization or the reductionism kick in? Because at a certain point you have to become useful knowledge for some other purpose, even if it's not capital T truth. And I think that's I loved kind of the way you put it about the point at which context kicks in or gets put on hold. And I want to think a bit more about how that works in these kinds of cases. Sorry, you use the word case a lot in a sentence, you realize as you talk. Because I think that is part of it, you know, what does get embedded in it as the necessary context and what gets put on hold, and when does it come back in, particularly as people reuse cases. But I haven't thought about it in terms of the terminology used, but I think that's interesting. The sort of context, you know, becomes background and context becomes the thing that you're actually interested in, right? And I think that's an interesting way to think about it. Virtues, intellectual virtue, I'm not sure. what is, I'm unsure of that whole sort of line, because I think it takes us down a path of maybe something that's good for teaching, but I'm not sure it gets to the heart of clinical reasoning. Might be useful, when we're talking about norms, particularly around ethical and social norms of good practice. What are the virtues of a good clinician researcher? I think that's an interesting question, because I think they involve trading off these spaces quite a lot, right? But I do think more generally, sort of more attention to not assuming the best case scenarios would go a long way to having a lot more equity, but also a lot more information that enters the sphere of being considered part of knowledge, right? And so that's to sort of say, I do think not full-flung virtue theory, but, humility perhaps, or awareness might be better of the limits of the way in which we construct knowledge under ideal conditions is much more necessary than probably has the point to date. And, in many ways, everybody's had their wake-up call. It may have been different, but COVID was one for lots of people, as I said, because well-resourced places were really struggling. And I think taking that more widely, it's great to write an article that's going to work where somebody's going to pay for the drug and it's all idealized conditions. But, I also think it's necessary to think about all those other contexts, and not just as populations. There's lots of individuals there who need treatment, and we often don't have information. So some of the more interesting case reports that I found are, here's what we did when we didn't have a proper X-ray machine, CAT scan, whatever. And here's what we found, and you too, in some place where your electricity is intermittent, could use this technique. I find those to be more interesting examples of democratizing case reports for the use of spreading valuable information than maybe the case report as a genre in itself. And that's where I think there's the need to, it's great to be able to treat patients in certain kinds of places at certain times, but the broader role of medicine is that kind of all those places where best practice doesn't even come into the mix. So that's kind of to talk around my problem with virtue theory. But anyway, yeah. Thanks. Yeah. Okay, sorry. Yeah.
Now can you hear me? Yes? Okay. All right, everyone here can hear me anyway. All right, so thank you very much. Some really interesting reflections. Diego, do just let me know if something comes through Zoom, because that's out of my sphere of vision. What I would like to do for the remaining time we have, which I think is about half an hour, right? Okay, so I would like to perhaps stimulate some more discussion amongst both the audience and the panelists. So if you're going to think of a question or a comment, do kind of direct it as something that each of our panelists could comment on. So it would take a bit of pressure off Rachel. She's it's at the end of a long day. So perhaps I can start with one such question, or prompt at least. So I think that both from your very interesting talk and analysis and the comments from the panelists, I think we can certainly see there is value for case reports and potentially case series, right? So there's a few more of them, but not enough to call it an observational study in a variety of contexts. But I also would like to prompt some reflections on where we might bound that up. Clearly, they're not going to, or maybe it's not so clear, take over the strength of evidence that a meta-analysis of 100 really, really well-designed clinical trials will do in terms of forming whether public insurance pays for an expensive medicine, for example. But so to some context for my my question or my prompt is coming from, so I've seen bad examples of case reports being abused for just commercial imperatives. So I'm thinking of the experimental therapies, certainly, so-called unproven stem cell treatments. I mean, a lot of the evidence that we see on those websites are case reports. and in fact, one of the professional organizations in the United States, it's claimed itself to be the international representative body. It had clinical guidelines recommending that doctors, set up a patient registry of their own, and gather, materials, gather data in terms of just case reports or case series, because this was sufficient. And in response to, the weaknesses where they do come into value is where, because, these types of therapies aren't amenable in randomized control trials. This is the this is the standard of evidence that we as doctors, a community of professionals, determine is good enough. And then of course there's the many anecdotal reports, and I've seen them quite convincingly dismiss criticisms of the approach. But I'm still yet to see any sort of convincing evidence that what they're doing works or is effective. Another context, potentially less problematic but more related to your examples with pandemics. So the WHO, after Ebola outbreaks in West Africa, because they didn't really know what it was, and there were lots, interventions being utilised in very under-resourced, poorly resourced health systems and hospitals. They wanted to be able to collect data, and so they came up with this framework called MURI framework, monitoring experimental interventions, or something. Which was quite pragmatically about providing a framework for, even though they were recognizing, look, it's better to do this in as research, as in a designed trial that gets overseen by human ethics committees. I mean, in a lot of these communities, they don't have that infrastructure. They just simply don't have it. So MURI was kind of like, look, this is the best thing we can do. If you're going to do it, detailing what you're doing, collect, outcomes data, and share that data, share that information with the wider scientific communities as soon as is practical. Okay, that was fine. But then when COVID came along, at least in my when I was sitting in Singapore, there was a lot of uncertainty about, what was going to be effective, and proposals of using various kind of interventions which did not have any kind of evidence base. So, for example, is it plasma, blood plasma, and then later, of course, came there was a couple of mentions of stem cell therapies again. So that was actually how it sort of came onto my radar, and then all the other sorts of ones. And the response we got from the doctors was like, look, no, we can just use MURI. It's like, no, but we're in Singapore and we actually have very good infrastructure for doing research. And we knew, we had colleagues who were on the research ethics committees, and they were prioritizing anything to do with COVID. There was no reason why they had to sort of go down that route. So that's just to sort of give some background on where some boundaries around case reports and as a sort of evidence base might lie. But prompt comments back from any of the panel.
Thanks. I think that's a really interesting question. Where does like a case report fit on the EBM pyramid, even if you simplify it back to what Rachel was saying before? Because I think in my area, at the same time as randomized control trials are really prioritized and important, with the recognition that each person is an individual disease maybe, and the N of 1, there's sort of a tension in both directions. And so there's always going to be an epistemic gap when you go from a science, whether it's or a data generation method, if you like, or evidence generation method, whether it's a randomized control trial or a case report, then trying to work out how it translates to an individual patient. there's challenges in doing that in an RCT context because you've got such a big, aggregated population of data and then trying to sort of put it to an individual. So some would argue that in the context of like recognizing that each person's an individual that you can determine by a specific biomarker, maybe there's less of an epistemic gap now for the case report because of, advances in molecular understanding and being able to characterize people by like small factors and then having a drug that immediately targets that. I don't think that's a be all and end all. And I think that's why I sort of brought up the issue of, I think the relevance of humility in that. But some of my colleagues would very much prioritize, there would be a sort of a strand of, I guess, medicine that would be wanting to put the case report way further up the EBM pyramid than it had been in the past.
I think it's quite interesting when you think about what I get when I get concerned about is the treatment of medical knowledge as being static, and I think the role that I see for case reporting is similar to the way in which we look at deviant cases in conversation analysis, and it isn't it's not always to prove the rule, but sometimes it can prove the rule, but it's also to shift our analysis and provide cumulative evidence for understanding a practice of social action. And I think that, promoting that kind of way of using case reports to, further scientific understanding. So we're not just assuming here's what we know and now we're building on it. It might be here's what we know and maybe we need to challenge that a little bit and understand that within whatever this new context is or whatever this new population is, just to, help that engagement with how dynamic, human life is and how dynamic that knowledge in medicine should be. That was, I think, do you have?
I also wanted to reflect a bit on what you mentioned as the abuse of case reporting. And back to a point that I mentioned earlier. So I think in some cases, actually, case reporting might, so this is one of those outrageous claims that I thought that I might make. Okay. So I think actually case reporting sometimes undermines the broader epistemic goals that we want to achieve. I think part of it is because, as I mentioned earlier, what counts as successful case reporting is not always down, or at least I want to argue, it's not always down to the use of abductive reasoning or the level of systematization involved or standardization involved. I think there are some political element, political, social, cultural element to case reporting. You mentioned one of the, Rachel, you mentioned pursuit-worthy judgments. I think so when you start doing case reporting, you do not do that in a vacuum. You actually have some judgments about what is pursuit worthy, what are the goals that you want to get with this reporting, and some of them are not directly epistemic. Some of them are just political, cultural, social, and they might undermine the epistemic goals in some cases. But again, I just put that forward. I want to see. Tamara, you said that we don't want to involve Rachel, but I just want to put forward to the audience to think about this claim. If Rachel doesn't want to comment on that.
Say not to involve.
Okay, but yeah.
So,
not
and actually, usefully, you've reminded me of something you said, Hoji, that I didn't answer. Of course, politics comes in, but the story I think about the early reporting on what we now know as AIDS, HIV and AIDS, was not a successful case if we take the norms of a successful case report to be a large number of citations. That's just not true, right? How does it get used and reused? Well, it's actually a complex story. We know a lot of it from the popular, but it does seem to be reflected a lot of communication within circles without necessarily publishing things, different modes of coming to understand and accumulate case reports, and so on and so on and so on. I think you can't say a case report has been successful without telling me successful for what purpose. Now, one of the purposes that I'm interested in, and that was one of the things that I was trying to talk about when I talked about pursuit worthiness, is that a case report could be said to be successful if it allows things to be formulated as hypotheses that then can be tested in other ways. That's a mark of success for the transfer of knowledge from individualized clinical kind of setting into more of a biomedical research setting. But that's only one way in which we might measure success. That's the one I'm primarily interested in because I'm interested in that interface. But to go back to what Tam was asking, I think you're asking, when is a case report a valid basis for a policy decision? And I want to say almost never, because that's not what it's intended to be. So you can only really judge, good, bad, indifferent, in a context against which it's trying to be used. It may be that a series could be used, but particularly where there's clearly a bad effect. So I think they're stronger as what we might call a negative argument, namely, again and again and again, we're getting adverse case reports, but that might be only 25 times. That might be enough to step back and say, let's take it off the market for this population or whatever else. It's much more difficult to use it as the basis of a positive intervention, and particularly where we have a whole set of structures and rules about how therapy should be tested and how drugs should be tested and so on. Furthermore, I think one of the key things about what makes, that maybe is generic, a case report valuable is the amount of transparency that comes with it. And so I put back to you, I think, a lot of the problems that lots of us have, including me, about stem cell tourism, let's call it, or shunky stem cell treatments. It isn't that they're reporting individual instances, it's what they're reporting them as evidence of, and what they're putting in it and what they're not making visible, either to the potential patients or to policymakers or to, other practitioners or whatever else. So it's not about the fact that it's a case report or a series of cases. It's about what they're putting in it and the use to which they're putting it, which is an inappropriate use given what they're willing to make transparent. Does that make any sense? So for policy claims, I really hate the whole dialogue around evidence-based policy, but I do think there is something to say that only certain kinds of evidence is probably going to be the basis of good policy, depending on what the question is. In some cases, these negative arguments are extremely valuable, right? Does that go some way sort of to answer it? So I think the boundaries for case reports, you can't put them down in a very generic way. I think there are ways that the standardization of what should be in them helps with things like completeness and transparency and so on. But when shouldn't you put out a case report? I don't know what that question would mean. When should you? I can tell you probably when there's some good examples where it would be useful. And I think one of the things about case reports are you often don't know what the payoff's going to be for a very long time. And that means we do have to sort of countenance and allow for this great diversity of stuff that might or might not come to be useful. I think we've had way too narrow of a definition of what's useful in the moment instead of looking across time, but also space to under-resourced contexts in particular. Yeah. Does that help a little?
Yes, yes. So, and I also think that so part of what Sarah too was, talking about the use and sort of seeing knowledge as not being static and that it is dynamic, and that as kind of knowledge changes, then evolves as new information emerges. That this is where they are particularly playing a really important role, because if they're not out trying to test a hypothesis of something that's already known, but is being able to illustrate or articulate some new phenomenon or some new information that is not yet testable in a hypothesis.
And the other one, very quickly, sorry, what this Sarah said made me think also, we always bemoan that, trials that get either negative results or really marginal positive results never get published. cases are a way to sort of take up some of that slack of the space of the uncertainty. And I think that's an important space. Yeah, that's what I was thinking when you, yeah.
Okay, so I got a bit confused by
I was trying to
Ainsley's
do miming
hand
with the
wiggling.
camera very unsuccessfully. So I was just trying to remind you, we did have questions before from Diego and from Maureen,
Okay,
who's
great.
Yeah.
in the corner, but she's now saying no. Okay, and then we also have a question on Zoom from Jade. Would you like to ask your question first, Diego? Or yeah, give you the floor.
Yeah, just very quickly, I think actually kind of builds off the last couple of points. So Rachel, you'd mentioned that in the case of COVID-19, when we have these case reports, so in terms of the process for abductive reasoning of case reports for COVID-19, you mentioned the idea of crowdsourcing, which makes sense in terms of instances where you have time pressures that you want to actually get as many people as possible looking at data. And the question is actually one of politics again. So we saw, I mean, I don't have to belabor the point, just the way that epistemology was weaponized in the context of COVID-19 and evidence generation. In terms of thinking through process, what does good process look like for abductive reasoning in cases where the situation or the context is so politicized when trying to look across case reports?
Yeah, I think that's a good question. So I think part of this is being able to have a much more robust account, similar to the kind of answer I gave to Tam, about what use you're going to put it to. And the best example I can think of off the top of my head was the evidence associated with the higher rates of myocardial infarction among teenage boys, right? And so in the US, tons of adverse event reports. The data was all non-parallel. It was very, very weak data. And it was a corpus of data that was very inconsistent in the way that it had been collected, often adverse event, but more so than usual. So the baseline, for example, of these boys' health was not there. Some of the things that anyone reasonable probably would have put into a database. It then got taken up, I would say, for political purposes, to make arguments about the relationship between causal claim about vaccination versus whatever. The problem got further muddied. So that was the US, of course. The problem got further muddied, though, in the UK, where they had some issues about resourcing, right? And these arguments entered into their thing, and they pulled back on teenage boys and vaccination force. I might be garbaging the story, but, you know, as someone fairly reasonable who reads literature, I suddenly got really concerned about my teenage boy and getting vaccinated and whatever else. I dug a bit beneath the surface and happened to know the right person to ask to find out completely political horse trading, you know, but I think that wasn't transparent to the average person on the street. To the average person on the street, you know, the woman who published the article that was subsequently withdrawn or retracted looked like a credible person just doing her job. Her job had nothing to do with anything related to teenage boys' myocardial infarction or vaccine. That probably was the first clue. So there are some norms around what gives you credibility and expertise. I almost in some way fault the British more for making a policy decision and not anteing up about resource constraints and kind of burying it under this kind of odd business about myocardial infarction, you know? And then on top of it, of course, I learned that teenage boys have a much higher baseline rate than I had any idea, right? You know, baseline knowledge, we all became experts in different things. But I think some of this stuff, particularly in times of these sorts of panics where it's not a moral panic exactly, but where we were combining arguments about resources, social norms, political decisions with scientific medical decisions, often despite not having a lot of evidence, there just needs to be a lot more transparency. And I have gotten into arguments about people who say, we can't tell people that. You know, you can't go around saying things like that. I had these arguments with people who work in the stem cell space, you know, to say something about like that is just going to cause people to panic. I mean, I think the reality is that medicine, whenever it's in practice, particularly in epidemics or at a public health level or whatever, is ultimately political, social, economic, and so on. And anteing up about that in a humble way, this might go to the other Sarah's original point, is something that needs to be done more, because otherwise we just create these sort of crazy false ideas around what counts as evidence. Yeah, sorry, that was a long, but that's in the COVID, I think it's the best example in the COVID pandemic that I can think of. Somebody else?
Let Sarah.
Just to touch on that, and even Hoji's point before, so you gave the example, Rachel, of a situation where case reports in the context of HIV, despite all we know now and all that's happened since, via one metric, was not successful, wasn't cited that much, etc. I'm just wondering, and like sort of thinking about where we sit now in terms of the access to science and data by a lot of stakeholders across social media, the X sphere, Twitter sphere, etc. A variety of stakeholders have the capacity to draw attention to different types of evidence. We see it in the context of clinical trials where data gets released early, or interim results, and that sometimes that's sort of poorly contextualized by other stakeholders. And I could see that could happen in the context of case reports too. So, and certain actors may have more or less noble, I guess, reasons for that. And we can't expect to police all of those stakeholders, but maybe just thinking about the producers or writers of the medical case reports, or people, researchers. Do you think there's like a role for like an ethic of, I guess, reporting, publicizing, drawing attention to, or not, like coming to sort of even Diego's point about what sort of gets publicity or not?
I mean, I think where it potentially gets a bit more dangerous again is now that there's this capacity to sort of combine things up using, large data modeling kinds of things. And you see people from outside medicine mashing things together and coming to conclusions. That's not safe. So I think that's part of what the people who put forward the care guidelines were trying to do, was to say there are better and worse ways to do this. Part of that is in the introduction, you are supposed to very clearly contextualize what this is and what it isn't. I think popular media, there is a sense which, you hear people say it all the time, it's just a case, whatever. I don't think there's any way to stop the politicization of these things. I think kind of luckily, if you will, publics are very wary of things that are just a case. I think it's more the opposite effect, that it's just, discounted as not worthwhile, right? I do think, it should probably be a bigger part of medical training than it is, though it has increased. So increasingly medical schools are teaching case reporting as distinct from, and I think this is right, taking a history, differential diagnosis, and problem-based learning, because it is sort of like some of what goes on. And I think that's a really good move. And there are some good tools that can be used to do that. They actually differ on some of the claims about what the epistemology is, because I've looked at it. But I think that's a move in the right direction, because if you're going to do it, you should be doing it in light of understanding what it's good for when it's good, if you see what I mean, what uses it might have, and yeah, and so on. Yeah. Yeah.
I think we can't escape other types of case reporting either. If we're thinking of mediatized environments and things like that, we have case reporting that comes from people, not just from medicine. And so I think, is there a greater value then in supporting people to understand, the difference between a single case or an anecdote and what that might mean, about your, someone's individual risk for a particular behavior or disease or whatever it is. So, helping with that kind of scientific understanding of science, I should say, rather than, worrying as much about, the positions of case reports per se. Yeah,
I can pass on the microphone, but I just is there any other person who wants to? Yeah. Okay. I just pass on.
Okay, so I can't read that question.
Yeah, I'll read it out loud. So this is from Jade. Could you say more about phronesis, respecting versus contempt for the wisdom and integrity of the knowledge of predecessors, and how can we shift contempt to respect for diverse sources of knowledge? That was it.
Yeah.
Yep, that's
Could you paraphrase that?
Well, I have an answer if you want to try.
Yeah,
So I think Jade's asking about sort of the last comment I made about practical wisdom or phronesis and kind of its role. I think we've been talking around that in a number of the answers lately, which goes to the idea that, there is sort of a contempt. We have modern methods, we can do things in modern ways, but yet there is a lot of information that we can get from things that aren't randomized controlled trials of the style today, as one example. So that goes to the information or the data or the understandings. I think we or whoever's doing these things can be more humble and more creative about using different kinds of information sources. Sarah mentioned using patients or individuals or people kind of as information sources in their own right, rather than just things that sort of passively give off symptoms. But I think the other part about practical wisdom or phronesis is that kind of the skill-based understanding and puzzle solving that good diagnosticians do. That's another part that sort of comes into play when we're talking about case reporting that starts from individuals. So I think it's a mixture of sort of different qualities, but it also goes to that kind of humility that comes with not forcing things into our usual epistemic or other types of structures. And that's something we've been talking about across the panel, I think. Yeah.
Great. Well, I think we could probably chat another hour or so, but we have bounded the time to 4 o'clock, and Ainsley would like the last 2 minutes to finish up the lecture today. So thank you all for coming, and I'll hand you back over to our chair.
Thank you so much. I think we should first give the panel a clap. Thank you to all of our panelists and to Tamara for chairing. So just a final amount of housekeeping to wrap up today's discussion. Firstly, just to say thank you again to all of you for attending. If you are not yet a member of our network, Sydney QR code on your left takes you to the membership form. So please feel free to use your device to scan that code. And then the code on the right is an evaluation survey for today's event. And you should be able to use those codes whether you are attending face-to-face or online. I also want to just say thank you especially to the Sydney Health Ethics Network support team, most of all Fran, but also Jing for coming today, and in the background, Susie and Kathy as well, and to our AV support team for all of the work you do in the background to make this event happen. Thank you very much for your time and for making it so seamless for us. And if you have attended today in person, there are some refreshments, canapes, etc., in the foyer of the building where we are now placed, and you're very welcome to join us. And I think there will be way too much food, because there always is, so you can skip dinner and eat everything now. And yeah, so I think that's everything from me, and so just remains to say I can formally conclude the event and see you all again soon. Thank you so much.